Distinguished Chairman, thank you very much. Distinguished colleagues, thank you very much. I would like to thank the organizing committee for inviting me here and for this beautiful organization. I will talk about the role of benzodiazepines in treatment-resistant anxiety disorders. I wanted to review this topic because it is a mode of treatment that we are using less and less. The goal of my speech will be as follows. I will first try to convey general information about the anxiety disorders and standard treatment. I want to talk about the idea of treatment resistance in anxiety disorders and the treatment options. I want to then go over the general characteristics of benzodiazepines and their use in anxiety disorders, and I want to talk about the use of benzodiazepines in refractory resistant cases of anxiety. Anxiety disorders since the 1980s have been subject to epidemiological studies, and it has been shown that they are the most commonly occurring psychiatric disorders. 1 year prevalence of anxiety disorder of any desired order is 12.1%. ECA study has reported a 13.7% prevalence. Lifelong prevalence is 28.8%. Roughly 1 person out of 3 to 4 persons is subject to an anxiety disorder throughout their lives at least once. Anxiety disorders have concomitant disorders, high treatment costs, disability potential, and the deterioration of lifestyle have been reported to be in parallel to that observed with schizophrenia. Panic disorder, generalized anxiety disorder, and obsessive compulsive disorder are disorders where treatment is pretty much agreed upon. However, with PTSD, the pharmacological evidence is inadequate. Specific phobia, that is not subject to pharmacological treatment as first choice. DSM-4 or ICD-10 says that any case of anxiety should be subject to treatment. When planning the treatment, we should consider the choice of the patient, the severity of the clinical picture, suicide risk, the previous treatment history, and the treatment cost. What is a standard treatment? In the past 20 years, evidence-based medicine says any treatment has an effectivity of 60 to 85% in the disorders of anxiety. With CBT, this is reported to be 60 to 90%. Almost all of the algorithms says SSRIs are first-line agents. When the patient cannot tolerate SSRIs, then serotonin noradrenaline reuptake inhibitors, TCAs, and monoamine oxidase inhibitors can be used, but it's not possible to say that they are more efficient, and it's not really possible to say that they are more tolerable. In anxiety disorder, what is treatment resistance? It is a more difficult concept to define in comparison to remission and resistance in depression, because the patient might be avoiding and therefore not showing anxiety. In anxiety disorder, recovery should be multidimensional and must be based on functional parameters. Based on these criteria, recovery is very rare, and anxiety disorders tend to fluctuate with a chronic course. Therefore, restoration of functionality back to normal can be considered to be a recovery. With standard treatments, based on these flexible recovery criteria, we can say that 30% of our patients recover through the standard treatments. What is treatment resistance? You have to know the past history. You have to be sure of the diagnosis. You should be sure that the patient is complying with treatment. You should be sure that the dosage is appropriate and the duration of use is appropriate. And if you are using more than one drug at the same time, then metabolic interactions might be interfering with recovery if there is resistance. Negative personality traits and other psychological traits also need to be assessed while trying to assess treatment resistance. If depression and substance use is together with anxiety disorder, then it's possible to have worse response to treatment. Psychological treatments on their own or in supplement should be assessed whether it has been used or not. What are the reasons behind inadequate response to anxiety treatment? First, pathology related. The ambiguity of the pathophysiology underlying anxiety. Is it congenital? Is it an infection? Is it genetic? Is it autoimmune? We do not know. Multi-neurotransmitter effects, complex receptor and reuptake mechanisms, and diagnostic difficulties. It is difficult to know what is inherited, what is not. The biological treatments at hand are empirical and limited. CBT's biological mechanism is not known. Environmental causes. What are the environmental causes? Childhood stressors, severe stressors, permanent stressors, and life cycle. For example, we know that adolescence is a stressful period in life. These all might be involved with inadequate response to treatment. Patient-related causes, severity of the disorder, concomitant medical diagnosis, psychiatric concomitant diagnosis. Doctor-related, lack of information, lack of CBT application, because of economic reasons, interruption of patient-doctor relationship. Treatment-resistant anxiety disorders. What can we use with treatment-resistant anxiety disorders?
Bitkisel tedavi. Herbal treatment.
Herbal treatment, pharmacological treatment, GABAergic anti-epileptics, which will be subject to discussion in the following lecture. Combined treatments can be used. Other treatments, especially for OCD, IV, anafranil, ECT, psychosurgery, vagal stimulation, and transmagnetic stimulation. What about benzodiazepines and their use in anxiety? Benzodiazepines pharmacologically are sedating anxiolytics. They are hypnosedative and anxiolytic drugs. However, in the psychiatry practice, they are used in anxiety disorder treatment, but they are not first choice in anxiety disorders. Benzodiazepines have pharmacological specific superiority. They have an anxiolytic effect, not based on sedation. Their pharmacological effects are similar. Low doses are anxiolytic, high doses are sedative and hypnotic. Benzodiazepines and their use in anxiety, panic disorder, generalized anxiety disorder, and social anxiety disorder are the disorders where benzodiazepines have been shown to be effective. Benzodiazepines have only been approved for panic disorder and generalized anxiety disorder by FDA. Alprazolam, clonazepam, and lorazepam are the most widely studied drug groups within the benzodiazepine family. Oral and parenteral application. After oral and parenteral application, their effect starts immediately. They do not cause an increase in anxiety, unlike antidepressants. Their confidence interval is high. However, they inhibit the central nervous system, causing somnolence, and there's a problem of dependency. There can be withdrawal symptoms lasting 2 to 7 days. Therefore, when starting the patient on a benzodiazepine, you have to calculate benefit very carefully. Against all of their limitations, in patients who are resistant to treatment, they can be used, but it should be used less than a year. The addition of CBT onto treatment can shorten the length of benzodiazepine treatment. Benzodiazepines are most appropriately used at the beginning of the treatment for the patients who are not tolerating antidepressants very well. With co-diagnosis, if depression or OCD is present, benzodiazepine has no effect on these. Resistant anxiety disorders and their use in benzodiazepines. In treatment-resistant panic disorder, the use of benzodiazepines. Alprazolam, clonazepam, lorazepam, and diazepam have been shown to be effective in panic disorder. However, in panic disorder, higher doses are needed in comparison to the other anxiety disorder. For example, alprazolam 4 to 10 milligrams per day need to be prescribed. In resistant panic disorder cases, usually they need to be used with SSRIs. What about treatment-resistant generalized anxiety disorders and benzodiazepine use? In generalized anxiety disorder, benzodiazepines used to be considered to be the golden standard. However, their use is limited today. In a meta-analysis, benzodiazepines have shown to be not effective in generalized anxiety disorder. In 21 studies showing the drug effects in generalized anxiety disorder, it has been shown that the effect size of benzodiazepines were 0.38. Interestingly, pregabalin reached the highest value by 0.5 and SSRIs reached only 0.36. Treatment-resistant social anxiety disorder and the use of benzodiazepine. In cases of treatment resistance, clonazepam, alprazolam have been shown to be among treatment options. The highest number of literature is for clonazepam. In social anxiety disorder, evidence-based medicine says benzodiazepines can be used in patients who are unresponsive to SSRIs along with SSRIs. Treatment-resistant OCD and the use of benzodiazepine. In resistant cases, clonazepam can be used as supplementation therapy. However, benzodiazepines, generally speaking, have no effect on the obsession and compulsions of OCD in terms of frequency and duration. Only it decreases the level of anxiety in the patient, and its effect starts in 1 to 3 weeks. Treatment-resistant PTSD and the use of benzodiazepines. Benzodiazepines are commonly used after PTSD. However, the studies have shown that they are not effective. In a study with alprazolam, it has been shown to be no different than placebo. However, interestingly, in a neuroimaging study, it has been shown that in PTSD cases, PZD affinity is lower at the frontal area, and it was thought that perhaps lack of treatment response could have been due to this finding, and perhaps higher doses could have resulted in response in these cases. However, in guidelines, benzodiazepines are not advised in PTSD treatment. In conclusion, PZDs are golden standards in certain areas of medicine, and they have certainly a place in psychiatry. However, evidence-based medicine dictates that they are not treating resistant anxiety disorders. They can only be advised to be used in short duration in treatment-resistant cases. These are my sources and maybe reading list. I would like to share this reading list further with those who are interested. Thank you. Thank you.